Welcome everyone. Before the coffee break, I would like to show you the one-year progress of my project, Physical Activity in Inflammatory Bowel Disease. I'm Emese Kasznár, I work at National Pediatric Institute, and my vision is to improve the management and quality of life of IBD patients. And for this, I would like to encourage IBD patients to exercise more to reduce their disease burden. I have 3 ongoing projects which are investigating the different aspects of physical activity in inflammatory bowel disease. The first one is investigating the disease activity and quality of life before and after exercise intervention in inflammatory bowel disease. IBD patients, besides their disease, tend to have decreased physical activity, bone mineral density, muscle mass, and they can also suffer from anxiety and depression. In 2022, there was a meta-analysis made in adult IBD patients, and it showed that physical activity can have a beneficial influence on these outcomes. So our aim is to analyze the effect of physical activity on a patient level. For this, we have a PICO framework, and the intervention can be any structured physical exercise, and the comparison will be the baseline measurements. So we would like to investigate the change in disease activity and quality of life. Here you can see our primary outcome, health-related quality of life, and as you can see, we used SMD because we wanted to include every study which we could. And we had 9 studies with moderate heterogeneity with over more than 150 patients. As you can see, the SMD was 0.55, which is a moderate effect. This means that patients can have better sleep quality, they can sleep more, or they have decreased depressive symptoms and anxiety. The reason for these examples I highlighted is because we made a subscale analysis. We had 4 subscales: systemic, emotional, social, and bowel. And as you can see, the highest SMDs were in the systemic and emotional subscales. These are clinically relevant for the patients and also statistically significant. Our second primary outcome is disease activity scores. Here you can see the Crohn's disease patient's disease activity score. The heterogeneity was moderate, and we could include children and adult studies as well with more than 200 patients. The SMD was minus 0.21, which was not statistically significant. The reason for this, as you can see, the patients who were included in these studies were already in remission, so there was not a big room for change. Here you can see the ulcerative colitis patients and their disease activity scores. As you can see, they had a moderate heterogeneity, and we included more than 100 patients with an SMD of 0.23. This is also statistically not significant, but we can see a tendency towards improvement. Here is a summary of our secondary outcomes. As you can see, we could only see statistical significance in lean body mass and aerobic fitness, but we could not see a clinical relevance in these outcomes because of the heterogeneity of the included studies. In the lean body mass, we included 3 studies, but although it was statistically significant, out of the 3 studies, 2 were made in pediatric populations, and only 1 reported Z-scores. In the aerobic fitness, also, the problem was the different age groups. So the strength of our study that we could demonstrate the beneficial effects of exercise on the patient level, and patients with IBD were analyzed separately according to their disease activity. Also, we did a comprehensive analysis on objective and subjective parameters as well. The limitations came from the heterogeneity of the interventions and the population as well, and sadly we were not able to analyze the data based on age groups. And another limitation is that the outcomes were reported in a variety of different units of measurements. The conclusion of our study is that regular physical activity improves quality of life, and there's also a tendency for disease activity scores to decrease, even in patients who are already in remission. implication for practice is to advise patients to engage in more physical activities, and the most multidisciplinary team should include physiotherapists as well. The implication for research is to include patients with active disease and children as well, and further research is needed to find the most effective physical exercise. Here you can see the status of our manuscript. We sent it to internal review last week, and the target journal is got. In our next project, we will compare the physical activity of healthy people and inflammatory bowel disease patients. As I mentioned before, the IBD patients tend to have reduced physical activity even when they are in remission. And we know that reduced physical activity can lead to many other chronic illnesses, such as metabolic syndrome, high blood pressure, osteoporosis. So our aim is to compare the physical activity of healthy population and IBD patients. For this, we created the PECO framework, and our primary outcome is metabolic equivalent of task minutes and time spent in moderate to vigorous physical activity. Our hypothesis is that healthy people are physically more active than IBD patients. Here you can see that I received some figures and tables and then started to write the manuscript. In this plot, you can see the summary of the physical activities. Because if it is a big plot, I put the SMD there, and you can see that it is minus 0.39, which indicates that inflammatory bowel disease patients are less active physically than healthy control. It is statistically significant and clinically relevant. We could include almost 1,000 IBD patients and more than 2,000 healthy controls. Here you can see our primary outcome, MET minutes. 1 MET means 3.5 milliliter per kilogram per minute oxygen to use by being active. So 1 MET minute means 1 minute spent in MET score 1. Here you can see that it was low heterogeneity, and we could include more than 400 IBD patients and 200 healthy controls. The mean difference was around 110, so there was not a big difference between healthy control and IBD patients. Here you can see the moderate to vigorous physical activity. Moderate activity refers to walking or cycling, and vigorous means like running and doing aerobics. Here you can see that the heterogeneity was moderate, and we could include more than 200 IBD patients and more than 150 healthy controls. And the MD was minus 15, which was statistically significant and also clinically relevant. So we can see that the moderate to vigorous physical activity that they spend in this is reduced in IBD patients. So let me jump to the third project, which will be a protocol for international randomized clinical trial. This will investigate the effect of structured physical exercise in children with Crohn's disease. A little bit of background. Pediatric Crohn's disease first-line therapy is exclusive enteral nutrition, which is a specialized liquid formula. They take it for 6 to 8 weeks. We have data on the improvement of lean body mass and bone mineral density during exclusive enteral nutrition, but the effect of muscles is unknown. 1/3 of adult IBD patients have sarcopenia, which means they have either decreased muscle mass or muscle strength. We do not know the effect of structured physical exercise on the prevention and treatment of sarcopenia, but we know that sarcopenia can lead to decreased therapy effect. It can lengthen the postoperative stay, and it can lead to osteoporosis as well. So we would like to observe the effects of structured physical exercise on the skeletal muscle mass. In this project, we are now at the sample size calculation part, and hopefully we will have some results on the next progress report. So in summary, I have 3 ongoing projects which are investigating the different aspects of physical activity in inflammatory bowel disease, and hopefully with these I can improve the quality of life of IBD patients. I would like to close the presentation with Carl Sagan's word, somewhere something incredible is waiting to be known. Thank you.
Thank you for your presentation. My question is regarding for your first and last topic. You mentioned structured exercise. What does it mean exactly? And what did the patient did? So what was the type of the exercise, the duration, the frequency, and the intensity?
Thank you for your question. So in the first project, there was a big heterogeneity in the interventions. In the pediatric population, they did yoga interventions or exergame interventions.
What?
Exergames. So it is like, it was mentioned in the first presentation today, exergames like Just Dance. So, you know, they are watching the little screen and they are copying the dance movements. And in the adult studies, most of them had resistance training or aerobic training or combined these two.
Okay, thank you.
Thank you.
The duration of the exercise intervention is also very important. Actually, you have a way, in addition to analyzing the forest plots as a whole, to check out the most effective or the least effective studies in your pool. So what seemed to be an efficient duration?
Thank you for your question. Most of the studies had a length of 12 weeks of intervention and had interventions 3 times a week, about 1 hour. And there were 2 studies which had an intervention of 26 weeks. And when we tried to do the sample size calculation for the third project, we saw that the highest change was in those studies which had the longer intervention.
Yes, and one more thing, when you plan the exercise intervention of IBD patients, these are youngsters. Their recommendation would be 1 hour per day, at least moderate or higher intensity physical activity. Is it feasible? Is it possible to reach that activity in IBD patients?
Hopefully, yes. It's based on the patient's disease activity status. So if in the third project, we are trying to do some kind of a personalized exercise intervention. So if they are not as good, not in a good status, then they have to do fewer repetitions or they have modifications in their exercises.